from the American Academy of Pediatrics.
More than 75% of high school students report experiencing at least one adverse childhood experience, or ACE.
A new National Center for Relational Health and Trauma-Informed Care offers pediatricians tools for taking care of patients and families.
We pediatricians, we've known all along how important safe, stable, nurturing caregiving is, and exposing children to typical experiences and events in their lives. And I think we now have the science that proves how important this is.
Plus, a new article looks at how medical jargon can be confusing for the teens we treat.
We often turn to medicalese for its efficiency or making us look smart, but it's a crutch. And so I think we really need to recognize it as a crutch to really recognize how poorly our patients are understanding this language that we use.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a look at the new AAP National Center for Relational Health and Trauma-Informed Care.
When it feels like things are chaotic or there's stress in your life, what do you lean on, Joanna?
Wow, that is a great question, David. I feel like with the news cycle, social media, the polarization of thought in the United States, it's a very stressful time, and I often just want to unplug. And what helps me do that is my family.
I felt sure that you would talk about Danny and your children because I also lean on family relationships to help me get through difficult times. And it makes me realize how important strong relationships are with people you trust.
I think about safe, stable, nurturing relationships a lot because I'm learning so much more about the science of early relational health while I work in the NICU. And that's why I'm so excited about the new AAP National Center for Relational Health and Trauma-Informed Care. And today we have two of its leaders.
Dr. Moira Szilagyi and Dr. Heather Forkey. Neither of these two physicians is a stranger to the podcast. Dr. Szilagyi is a past president of the AAP and a primary care pediatrician, professor of pediatrics, and division chief of developmental behavioral pediatrics at the University of California, Los Angeles. She did a Pathways with us for episode 130 and also talked about trauma-informed care with us way back on episode 82.
Speaking of episodes from way back, Dr. Forkey joined us on episode 9 talking about foster care. As a reminder, she is a professor of pediatrics and director of the FACES Clinic, which stands for Foster Children Evaluation Service of UMass Memorial Children's Medical Center. Moira and Heather, welcome back to the show.
Thanks so much.
Thank you. Great to be here.
Whenever we talk about childhood trauma, the concept of adverse childhood events, or ACEs, comes up. Heather, can you remind us how ACEs shape child development?
So sure, kids are exposed to tough things all the time. They have challenges at school. They have challenges with peers. But what happens most of the time is that these things are buffered by the people around them. Things that you guys mentioned, even in the introduction, those safe, stable, and nurturing relationships. And so kids can use the most effective stress response, which is the affiliate response, turning to others and saying, hey, can you help me with this? And it mitigates the stress and kids do well. Unfortunately, some kids experience tough things that are really tough, and they do it without that buffering support, either because their caregivers can't provide it for them or they're in a circumstance where they don't have that provider support. And that means you can't use the affiliate support and you wind up overusing fight or flight or stress responses, which are not as effective and are meant to be very short term. And when that happens, that can cause stress on the whole body and brain, leading to what we call in pediatrics toxic stress.
So the counter to things like ACEs and toxic stress are PIECEs, which are positive childhood experiences. Moira, can these pieces erase damage caused by ACEs?
Well, that's a great question because there is a lot of evidence emerging from science in the last several years that Positive childhood experiences are actually very powerful and can ameliorate the damage that can potentially be done by being exposed to ACEs. So some work from Christy Bethel at Hopkins and Adam Sugadance at our own institution have shown that having strong relationships in childhood in particular, but also exposure to a variety of experiences, many of which are also relational, can really dampen the effects of ACEs over time. And they did a reanalysis of the original ACE study recently because they always knew that there were individuals in that study who had high ACE scores, but went on to have good outcomes. And there were some individuals who had low ACE scores and had bad outcomes. Now, the ACE score did not include every potential trauma that somebody could face, but it also did not include those positive childhood experiences that individuals often have that build their resilience skills and sustain them over time. So I think what we've learned from all of those is that PCEs are very powerful and necessary in children's lives for good outcomes. And at the center of that, I would put what you mentioned, safe, stable, nurturing relationships.
And Heather, do you mind mentioning that again, exactly how safe, stable, nurturing relationships act as a buffer for toxic stress?
Sure. I mean, I think this is what's so much fun about pediatrics is that we get to see how the people who are around kids modulate the events of life so that kids can thrive. So we have a number of stress responses. We can freeze and hope that the threat goes past us and doesn't notice us. We can try to run away from it or fight it. And those, for kids, are only sort of moderately effective, right? The kids can't run faster than adults, and they don't have claws, or they can't hide underwater. They're not really good at those. So we evolved to have a stress response which used what humans have most effectively, which is our brains and each other. And under most circumstances of stress, kids turn to other people and they say, hey, can you help me deal with this? Can you help me manage this threat? And that's oxytocin mediated. And it means that you gather people to you and you deal with the threat, and it doesn't have severe physiologic consequences. What happens for some kids when they are experiencing threat without that affiliate support is that there's an overuse of freeze or fight or flight. And no, those are mediated by other hormones like norepinephrine and cortisol and epinephrine. And what that means is those hormones are not designed to be flowing through developing brains and bodies for a long period of time. They're designed to be very short term, quick bursts so that you can get out of a really sticky situation to get back to affiliate supports. Except when kids have too many experiences where they're constantly unable to use affiliate and have to use fight or flight or freeze, it has impacts on the body and on the brain such that there are changes which are initially adaptive. They help kids survive in the short term, but over the long term, they have consequences, which we see in terms of diagnoses and developmental challenges and behavioral health challenges.
So in light of this new understanding, the Academy has said that we should approach all interactions with our families through a lens of trauma-informed care. Heather, can you help us understand how the new National Center for Relational Health and Trauma-Informed Care will help pediatric clinicians do that?
So I think people have heard the term trauma-informed care, and it sounds like a good idea, but it's a very vague description, and it doesn't tell people what am I supposed to do exactly. And how do I do that with the time that I have with families, either in the office or the hospital setting? And what the new center is trying to do is get to pediatricians the resources so that they know how they can do this work, promote affiliate response, respond to kids who've already experienced trauma in ways that are efficient and effective and very practical for the different circumstances that they find themselves in. So that's our goal. We really want to get the tools into the hands of pediatricians so that this isn't just a good idea, but is something that people can do all day, every day, in whatever interaction they're having. If we have a child who's impacted, how do we screen for both exposure and symptoms to get them immediate help and guidance for their family, get them referred to places where they need to go for evidence-based treatment? And for kids who are in our primary care settings or even in the hospital and they're not experiencing trauma symptoms, how do we equip families to promote PCEs and help support that development of resilience, so those kids don't go on to develop trauma symptoms when the inevitable events of life happen.
And the name of the center includes both relational health and trauma-informed care. Moira, are these two things the same?
Yes, the short answer. I think relational health care encompasses trauma-informed care, but also describes very much that trauma-informed care is relational health care. And what we mean by that is in our relationship with families and patients, we have to do that in a way that creates safety for them so they feel safe engaging with us. So that means both physical and psychological safety. We do this every day in how we greet patients, how we ask about their concerns, how we listen and empathize, how we seek more information in a way that's curious and not blaming or shaming, how we reflect back to them what we're hearing to check in with them and make sure that we've got the picture, and how we partner with them in trying to understand the context of their lives, their culture, while we bring our medical expertise to bear on it. So that relational term applies to both our engagement with, in this case, mostly the parent around the child's health, but also with the child, and how we then use that to center the parent-child relationship in a way that supports and nurtures that relationship and helps the parent build skills. And I think that, trauma-informed care is not just identifying and ameliorating risks or identifying and ameliorating symptoms and healing after traumas occurred. It is also, as Heather said, that it has a primary prevention component. Relational health is the foundation of that. We have to help parents build that safe, stable, nurturing caregiving that creates the context for the child to develop resilient, adaptive responses so they can manage the stress that they're undoubtedly, we all encounter stress in our lives, some of which helps us learn and grow, and then some of which is less positive, the challenges of hurricanes and floods and people in your family being sick or passing away. These are all things families go through together, but families also sustain their children through those.
And I feel like some pediatricians listening might feel some stress about how they're going to be able to incorporate these concepts in their busy clinic days. Will this center help empower them to do that?
Yes, I hope so. We just gave a joint talk on what you can do with 5, 10, and 15 minutes. And I covered the preventive end of that, what you can do in 15 minutes, which is really all that relational support and care, much of which I just mentioned. And Heather can probably speak better than me to the 5 and 10 minute pieces that she covered.
I think what we were trying to point out as we discussed that is that, in medicine, we're constantly under time pressures and constantly trying to address a myriad of health issues. This is one more, and we apply the same tools that we always do. If you have 5 minutes and you have to get through it, you triage, you deal with the most urgent, immediate thing. And what you don't want to do is miss diagnosing a child who needs immediate care for a trauma-related issue. So how do you screen for that? How do you respond to that? How do you get them the care that they need urgently? If you have more time, I think what we're talking about is building more of those relational supports with whatever minutes that you have, right? How do we incorporate that capacity to have that patient feel understood and feel like that's a safe affiliate of support in our places where we're providing care? And how do we build that with families? And then, as Moira pointed out, we can take as much time as we have and do more and more of that. But I don't think that this is very different from the rest of pediatrics. I can do asthma care in 5 minutes, 10 minutes, or 15 minutes. Just tell me, how urgent is it and how much time I have, and I'll prioritize what we do first, second, and third.
And Heather, while this center is new, the AAP has a long history of promoting safe, stable, nurturing relationships and trauma-informed care. How will this new center incorporate all of this history of the AAP's past work?
I think it's really an exciting time in 2025. We started back in 2012, really beginning to identify of course, people have known about trauma for the eons of history, but we began to put a name to it and understand its effect back in 2012 when Dr. Shancroft and Dr. Garner published the toxic stress papers. And then I think from there, people began to sort of try to figure out, well, what can we do about this? More recently, we've had Dr. Garner and Dr. Yeoman come out with the relational health guidance. And what we're doing is, as a center, highlighting all of these advances in terms of our understanding and the tools that we have to address this, both in prevention tools and treatment tools. And I think that's what's so exciting for me, because we really are decades into this work, and the center is ready to get those tools that have been decades in the making into people's hands.
And Moira, what are some of these tools that pediatricians can look forward to from the center?
Well, there's already quite a bit up on our website at aap.org/trauma. And, we have our original series on the pediatric approach to trauma treatment and resilience, which is 18 sessions on childhood trauma and resilience. We have 2 PediaLink courses. That is a total of 12 sessions, I believe. We have some short case video vignettes kind of showing these skills in action with Dr. Forkey, otherwise known as Dr. Talent in certain circles. We just launched our 6-session training for residents that comes with standardized cases. We have some short videos on trauma-informed concepts. We have infographics that pediatricians can use to remind themselves of some of the approaches in this work, such as teaching parents about the 3 R's, reassurance, routines, and promoting self-regulation. So there's already a lot of stuff up there. We have more training materials coming. We have a training for pediatric outpatient staff that will be live, hopefully in the not too distant future, that we've piloted and had reviewed. We're now developing a training for inpatient pediatric staff. We're doing some special populations like foster care. And we hope to have material up on adolescent trauma specifically. Probably not this coming year, but we'll probably put out some parent resources and then work on a deeper training for pediatricians in the next couple of years. So lots of stuff. I feel like we're building the bicycle and riding it at the same time, just a wee little bit. But as you say, there's a long history at the AAP. And I think what happened, as Heather said, is with the toxic stress policy statement, there was a bringing together of all of the science in early brain development, child development, attachment, and then epigenetics that really gave us the biological foundation for work that we pediatricians, we've known all along how important safe, stable, nurturing caregiving is, and exposing children to typical experiences and events in their lives. And I think we now have the science that proves how important this is.
So I think not only children, but maybe all of us in this moment could use some trusted relationships to lean into. I would love to hear a takeaway from each of you about how we can seek these things through the AAP, through the center, or maybe even beyond them. Heather, can you start?
I think, the bumper sticker we have come up with, it's not about summing the suffering, it's about building the buffering. And I think what's true about that is that it is really about these affiliate relationships, that what you want to do is you want to seek for yourself and for your patients those opportunities to connect with others. We have this concept in American culture that you figure yourself out and that you just do it on your own. And of course, you don't. You never do. We understand ourselves and we understand the world only through people reflecting that to us. And so, particularly at a point when we find that some of what's reflected is, distressing and disturbing, turning to others who can reflect what we want to see and the future we want for ourselves, for our patients, and for our families is the way to go forward.
And Moira, thoughts?
Your question reminded me that in 2022, when we had our first in-person NCE in a few years, our national conference, that as I was walking around, and I was somewhat recognizable to many pediatricians at that point because I was president, people would walk up to me and say, the AAP saved me over the last few, still makes me want to cry. And they told me story after story about how hard the pandemic and the isolation was on them and the families that they cared for, and how much just hearing your voice is undoubtedly on this podcast, but having groups at the AAP that they were involved in or their chapter work, and pediatrician after pediatrician used that phrase. And I thought that spoke so deeply to how much we depend on and rely on each other. And so I encourage all pediatricians, be a member of your chapter, join groups at the AAP that you care about, that's addressing topics that you're passionate about. And if you have a chance to go to an in-person meeting and really spend time with your colleagues, it's so rejuvenating.
Well, you almost had me in tears there too. Dr. Szilagyi and Dr. Forkey, thank you so much for joining us today.
Thank you, guys.
Thank you.
For more on trauma-informed care and the National Center for Relational Health and Trauma-Informed Care, visit our website at aap.org/podcast.
Coming up, we'll look at how the medical jargon we use can get in the way of our communication with teens.
I know you like when I run my infant cases by you, David. I recently had an X29-weeker admitted for respiratory distress with negative imaging but significant rhinorrhea and concerns for post-tussive emesis and a viral exanthem.
Well, you got to assume a viral pathogen in any case like that. I'm just going to pause, though, because our producers look a little lost. Do you want to translate that for people?
Oh, man, I just went into jargon oblivion, didn't I? It's so easy to do when you're talking, and thankfully our audience is a lot of pediatricians.
I was especially struck by episode 233 in January when we talked with Drs. Michael Pitt and Rianne Maravelis about their study, Children's Understanding of Commonly Used Medical Jargon. Some of the misunderstandings were funny, but it was also sobering to learn how often our patients and their families are not getting the information we think they are.
I have good news. That same research team did not only survey children, they also spoke with teenagers. And they published their findings in Hospital Pediatrics in an article entitled Lost in Translation, Teenagers' Understanding of Common Medical Jargon. Today we have two of the authors on that study, Dr. Aarabhi Rajagopal and Jordan Marmet.
Dr. Rajagopal is a senior pediatric hospital medicine fellow at the University of Minnesota, and Jordan Marmet is an associate professor of pediatrics in the hospital medicine division and division director of pediatric hospital medicine at the University of Minnesota. Aarabhi, Jordan, welcome.
Thank you so much for having us.
Thank you.
So give us some background here. Jordan, how often are we confusing families with medical jargon? And have we ever asked teens their thoughts on this before?
Well, that's the very question that was troubling us when we came to this dilemma. We recognize that we're often using our inside language, our jargon, and you can go to the auto mechanic, you can talk to a plumber, you can talk to anybody, and they have inside jargon. In medicine, we have reams of it, right? You can barely read it in an ophthalmologist's note without recognizing that it's all full of letters that mean nothing to an outsider. And we use this conversation all the time in front of patients, thinking that they understand. So our research team really wanted to get at that, the question of how often is it used. And so we did a survey on our wards during patient rounds of collecting information and even getting like a jargon score per minute. How many words are we using at a time or per encounter, which was eye-opening for us. And then looking through this paradigm that colleagues on our team had created for dividing up jargon into 7 different categories. You were aptly calling it jargon oblivion. That was the name of their paper, saying that we in medicine just forget how much we learned in medical school and in our training and in our practice along the way, how little we knew before we were inculcated in this field.
Aarabhi, what sorts of terminology did your study focus on when you were talking to teens?
Yeah, great question. So we had done a previous study with adults that focused on different types of terminology, including acronyms and things like positive and negative, and common phrases such as like, you have bugs in the urine, to like reference UTI. And we had seen in adults that, understanding was variable, and so wanted to kind of double check that and see how teenagers understood it. And overall, teenagers did way worse than adults did, especially the more complicated the jargon phrase got.
And jargon exists because for those within a field, it's so precise and so efficient. So what do we risk, Jordan, when we fall back on using medical terms that patients may not understand?
Yeah, exactly right. In the what do we risk, it's that if they don't understand us and they don't ask questions, then they're left out of the shared decision making. We're not taking their opinions to the table, or they don't understand why they're supposed to take such and such medication that we have 2 names for instead of 1, right? And who knows which name we'll throw out at any given moment. And so they may not be compliant is a jargon word unto itself. Hey, you're non-compliant. That's very judgmental. We put that into our judgmental jargon category. But it might just be because they didn't understand the plan. They didn't have a stake in the plan. And so there's a lot that's at stake there.
And this study was done at the Minnesota State Fair. 2 questions for you, Aarabhi. Why the fair? And did you try the corn dogs?
I didn't try the corn dogs because I'm vegetarian, unfortunately. But I think there was a vegetarian one eventually that I found, like not that state fair, but like the state fair after. And the state fair for 2 reasons. 1, because it's the best event in all of Minnesota. And 2, it's a really great place actually to do studies because you have a large percentage of the Minnesota population from all walks of life show up at the state fair. And a good percentage of that comes into our research booth at the state fair to answer survey questions. And so it's a great way to get a good cross-section of the Minnesota public.
And for people thinking of doing these studies, did you offer incentives to the teens to come to your booth?
Yeah, anyone that participated in the survey and completed it got like a drawstring backpack that had a university logo on it as an incentive.
And to sharpen the point on that, our Minnesota State Fair, it's the 2nd largest in the nation. And so that's why Aarabhi was, taking credit for it. But it's compressed in time. It's over 12 days. So the 12 days leading up to Labor Day each year. And it has a huge number of attendees. So there's about 2 million attendees at this state fair each year across those 12 days. And we're in a state that has a population of a little under 6 million. So it's like you could estimate that 1 in 3 people within the state show up at the fair. So it's a great sort of cross-section. We could set up a research booth in a clinic, right, and have biased results because, and some people have done this, you're in a breast health clinic and you're asking people, do you know what an oncologist is? And do you know what a radiologist is? And surprisingly, a small number of people know those things, even in a breast health clinic. But you're biasing your population because you're sampling it in a clinic. You could set up a booth also in a grocery store and just, get a real cross-section of the public and have a really long time trying to recruit patients. So we're at a venue where we have a cross-section of the public. And then there's also an investment of resources already. We have a research booth that our Department of Epidemiology has invested money in. It's a brick and mortar building where they have research tables and, chairs and iPads that we can use to conduct our survey. So we had the public, we had the space, we had a beautiful cross-section of the population that's there. And so it was a perfect ground for asking the general public, do you understand what this means? If I say a pediatrician is a doctor who specializes in blank and you say feet, then I'd go, aha, you're thinking it's a podiatrist. But we can see, how many actually know that a pediatrician specializes in children. And it's about 90%, by the way.
That is reassuring. And I have to say, by the way, as a North Carolinian, I'm now feeling State Fair competitive with y'all up there. But after all this research, what did your team find? Are we doing any better communicating medical information to teens compared with how we're doing with adults?
Yeah, great question. I would say, if we start with simple things like saying we did a cancer screening test and that came back negative, or we checked this strep test and it was positive. There's like 95+% of teenagers that usually understand that, largely probably because of the COVID pandemic and kind of understanding positive versus negative. You start adding in more jargon, like saying your chest x-ray was unremarkable, or the findings were quite impressive, and it's less and less, kind of trickling down towards like 50%. If you try to simplify it, for example, if we said your blood culture was negative, there was, about 52% that understood that, but saying that, there were no signs of infection meant that about 80% of people understood it. You throw in acronyms like NPO and nobody understands. And there's some fun facts in there too of like some of the words we tested that no one really understood. But by and large, the more complex it gets, the less they understand.
And given that we often think we're speaking clearly, and many of us are wrong about that, what advice do you have for us to make sure we're really being understood? Jordan?
I think we have to put ourselves in our patient's shoes, right? We have to think about, when am I throwing around acronyms? When am I saying CBC to somebody who's medically naive? Or you're going to be NPO for the procedure tomorrow. When we say to kids, we're going to have surgery come see you, they think they're getting an operation, right? So things that to us may be benign, we have to try to be empathetic in that sense of putting ourselves in our patient's shoes, testing their medical sophistication, so somebody who has XYZ rare disease probably knows more about it, and their parents know more about it than I ever will. And so respecting their knowledge, but doing a check-in. I think using teach-back, becomes all the more important. When I'm seeing somebody in a hospital situation, maybe they've already been to a clinic and an ER or an urgent care, and then they're here, and maybe I'm seeing them the next day or even 3 days later. And so at this point, I can just do a quick check-in, like, so, what's your understanding of bronchiolitis at this point? Rather than, let me open up, pour out to you a 5-minute dissertation on what bronchiolitis is. There's people of all different kind of sophistication. So just a quick check-in with a child, of different ages or different cognitive abilities, with a parent, seeing where they are, can really help frame a conversation up.
That is great advice. Well, this conversation, I think, has left our listeners hungry to read this paper and get all the data. It's left me hungry for cotton candy. But before you leave us, can you each give us one takeaway for our listeners to remember? And Aarabhi, do you want to start?
Yeah, I think my favorite fun fact from this study is that teenagers don't actually know what febrile means. And somehow it's a word that's, crept into my everyday vocabulary. But it was really eye-opening to realize that about 13% of our teenagers thought that it was related to either sexual activity or fertility. And so I think just recognizing in and of itself, like when you're using jargon and making sure to, repetitively ask and do teach back to make sure that your teens understand as they gain more autonomy in their healthcare decisions and those sorts of things.
And how about you, Jordan?
Yeah, so febrile is a great example, Aarabhi. Occult infection, 0% of the teens we screened, ages 13 to 17, understood what occult meant. More thought it had something to do with witchcraft. And when we check adults, by the way, only 2% of adults knew what occult is. So there are just things that we say on a regular basis that we can simply strike. We can talk about, lower extremity instead of your leg. We talk about ambulating instead of walk. We talk about, NPO, and you can spell out NPO. Oh, that's Latin for nil paras. What does that mean? It means don't put anything in your hole. What do you mean by that? It means don't put anything in your mouth. What do you mean by that? Don't eat or drink anything. We often turn to medicalese for its efficiency or making us look smart, but it's a crutch. And so I think we really need to recognize it as a crutch, to really recognize how poorly our patients are understanding this language that we use, and then think about some really good substitutions. So if non-compliant isn't great, how about didn't take? If chief complaint, something we use all the time, so ingrained in us, right? But if we said that to a person, oh, you come in complaining of a sore throat, and be like, I'm not a complainer. So why can't we say the main reason for being here? It's a couple more words. Maybe it's a tiny bit less efficient, but we really can, simplify our conversation.
Doctors Aarabhi Rajagopal and Jordan Marmet, thank you so much for joining us today.
Thanks for having us.
Such a pleasure to be here. Thanks for having us.
To read the article, Lost in Translation, Teenagers' Understanding of Common Medical Jargon, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
So I know you've spent some time with family recently, Joanna, and we have too. Over the Easter weekend, we got to have a big gathering that included not only my wife and 4 of our 5 children, but also my ex-wife and her dad and his wife. And I just love that this many years out, we are all still having such a good time together and relating and gathering around the holidays. And I never want to take that for granted because I just really appreciate remaining close with all of these people.
I want my Say Ah to be very similar to that because we celebrated Passover because my husband is Jewish. And have you been to a Passover Seder, David?
I have been to many, yes.
Good. I mean, it's really fun. And I didn't start really going till I was an adult because I was not raised Jewish. And so we just had this wonderful large family gathering. And my favorite thing is seeing all the cousins together. And I hope that they remember these times and the effort that went into getting us all in the same room. Because it's just so nice to see them have those friendships that I hope they'll hold throughout their life.
That is great. If it tells you anything, my springtime after-school snack was matzah with margarine on it.
Yum.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss the May issue of the journal Pediatrics.
We'll talk to Deputy Editor Dr. Alex Kemper for a new First Up. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.